So today I want to focus on a couple things here. I'm not going to go into everything that one needs to think about when they're looking for a practice opportunity. Obviously community, that's a very personal decision. I don't know that I could necessarily add anything to that dimension of the job opportunity, other than to say, I'm sure most of you have a smartphone, so an app that I really like to use is Realtor.com. So if you're looking at a community and you want to get a sense of housing prices and what's available, Realtor.com has been a fantastic app, and I recommend that to physician candidates with whom I'm working. So the items in blue is what my presentation is going to focus on. The reasons for recruitment. This is mainly from the standpoint of why is the organization recruiting for, in your case, a pediatrician? Just some things to consider. Scope of practice is another thing you'd want to look at. And then obviously the practice environment as well. Timing and availability, I think, is a self-evident kind of thing, so I don't really think we need to spend time on that. And then of course compensation and benefits, and I'll spend a little bit of time going into some of the particulars of some of the trends in compensation. So if and when you're considering a new job opportunity, something you want to consider and perhaps ask the organization is, well, why are you recruiting now? Perhaps it's because the organization is dynamic, they're expanding, they're growing, and so the reason for that recruitment might be strategic in nature. Perhaps there's a community need for a pediatrician if it's underserved in that particular specialty or practice area. The other reason might be replacement. And sometimes when I talk with practicing physicians, they seem to be a bit assured if they know that a recruitment is for replacement reasons rather than, let's say, a brand new startup practice opportunity. And that's good, and I think there is some level of assurance with replacement recruitments, but what you might want to consider is, well, okay, is this a replacement due to someone's retirement, or is it a replacement due to someone who maybe was with the organization for 3 years and has not renewed their contract perhaps, or maybe the organization didn't renew the contract and there's still a need in the clinic, maybe from a call standpoint, maybe from a volume standpoint, but it's not necessarily a retirement situation. And again, even with retirement, sometimes one thing you might want to ask some of the partners in the group, assuming there are other partners, is, well, this person that retired, were they kind of in slow down or shut down mode for a number of years? Because again, if they've kind of been scaling back as they're approaching retirement, there might not necessarily be a captive patient base that you could walk into when you're starting up a practice. Another reason might be defensive in nature. An organization maybe faces some stiff competition from another healthcare system within the community, and perhaps their competitor is looking to recruit a couple pediatricians, and the organization may feel as though, well, if we don't recruit our own, we'll stick with pediatricians, if we don't recruit our own pediatricians, that's going to put us at a competitive disadvantage in the marketplace. So again, it could be for growth reasons or community need, but it could be that an organization is recruiting as more of a defensive reaction or defensive posture relative to their competitors in the marketplace. And then the last reason would be call coverage. As you look at these reasons for recruitment, and then these are very broad categories and broad generalizations, perhaps an organization may be recruiting for multiple reasons, but again, if we just look at this simplistic analysis, generally speaking, as you move down this list, there will involve or potentially consider a pretty significant subsidy by the organization. So if the organization that's looking to recruit pediatricians is a hospital-based organization, if they're recruiting for call coverage, it's very possible that the organization is going to need to subsidize or underwrite the salary for that particular position relative to, say, a recruitment that's based on strategic reasons. Another point I'll touch on later when I talk about compensation is as you move down this list, generally speaking, and I'm talking very generally, the chance to hit productivity targets may potentially decrease. So you want to think about this in tandem with the kind of offer an organization might make to you. So if an organization is saying, well, we'll give you a base salary, a very small base salary, but really we want you to be incentivized to work hard. So let's say 80% of your compensation package is work RVU based, for example. Well, if you're potentially going into a position that's purely based on call coverage needs rather than strategic or growth reasons or rationale, you may have some difficulties hitting your productivity target. So again, there's a couple things you really want to consider in their totality and in their tandem as you evaluate not just the practice opportunity, but also as you evaluate the compensation package that an organization may offer to you. Other considerations as you're looking at job opportunities is, well, what's the scope of practice? Is this a full spectrum situation? Is the organization going to expect me to attend at C-sections, care for newborns? Is this a practice that doesn't necessarily involve care of newborns, but still requires some inpatient admitting, attending, and discharging responsibilities? And then along with that, what are the call considerations here? Two types of call you need to consider. Well, there's my practice call, and then there's the community call, and they're not always the same situation. So, for example, we're recruiting for a rural pediatrician to work in Fruitland, Idaho, which is right on the Idaho-Oregon border. The hospital associated with that has roughly 600 deliveries a year, 200 of which are C-sections. They're pretty good about protecting the pediatricians with having to respond and come in for the C-sections. It's a level 1 nursery, and there's an independent group of physicians in this small town in Ontario, Oregon, 4 of them. So we're recruiting pediatricians to work for our organization. The community call would be shared with the one independent group in town, of which there's 4 practicing. But practice call would be shared internally with our medical group, family practice physicians, perhaps our nurse practitioners and PAs. So those could be 2 very different numbers, and the frequency and intensity thereof could be variable between the 2. So, and then of course there's the clinic. Where's the location? How close is it to the hospital? Is it on the hospital campus? What's the staffing mix? If I'm going to work here as a pediatrician, will I be provided with a registered nurse, an LPN or an MA? How much say do I have in the hiring and in the personnel management decisions with an RN, an LPN, or an MA? And then what are the productivity expectations for me? Then of course there's a practice environment. Again, as you look at opportunities, particularly for residents and fellows, try and give some of this some thought about, well, what do I want to do inpatient responsibilities, or am I looking purely ambulatory? If I'm willing to do some inpatient, well, what's the size group? How frequently do I want to be on call? And maybe you might be recruited, an organization may say, well, we want you to work in a 1 in 4 situation. You're like, wow, well, that's a lot of call. But if it's at a community hospital with a fairly low pediatric inpatient census, maybe the frequency of call is high, but the intensity isn't necessarily as high. So there's a couple ways to look at that and consider that. And then how are decisions made? So these 3 bullet points here, this, I think, particularly in recruitment, if you're looking at an opportunity, you say, well, what's the longer term plan? Are you looking to recruit 1, 2, 4, 8? And then how do you make decisions about when you're going to recruit that additional pediatrician? Will I have a say or involvement in that decision and making that determination? Is it something that's purely administrator or CEO driven? Some of these things will have a big impact on the long-term viability of your practice, and I think it would be insightful for you to consider and ask these kinds of questions when you meet with the administrators. And then a lot of pediatric practices have already moved to a patient-centered medical home model. Others, our organization is piloting that in a few pediatric clinics. And so just because there isn't a patient-centered medical home model doesn't necessarily mean there might not be one in 2 years. So again, you may want to ask some questions about that. So compensation models. Historically, a lot of compensation models, particularly in private practice, were based on income guarantees, but a very small percentage of income guarantee comp models are really out there in the marketplace. I think since 2006, I saw one survey, the number of income guarantee comp models has decreased 63%. Salary only is certainly out there, although there was a focus study done in 2010 that indicated that most residents and fellows, 83% of them, granted it's a focus study, it may not be statistically valid, but the focus study residents and fellows, the participants in that, indicated that they actually preferred some level of productivity, so more of a salary plus, base salary plus a production model. But more and more organizations are moving toward sort of a hybrid package where you'd get salary, which is nice, it provides you that steady paycheck, the productivity incentives, and then of course quality. And it's not, again, having the insurance background, it's not coincidental that a lot of insurers are starting to pay for outcomes and quality. So healthcare organizations are following suit, and now they're compensating their physicians to focus more on quality than perhaps just a volume-driven focus. And so my economics teaching background, I don't remember who it was, some famous economist, but he said you can sum up economics in 2 words: incentives matter. And I liken that to physician compensation. It's all about the incentives. And so when you're looking at that offer package, is it productivity? Is it volume heavy? What's the quality component to my compensation? It will tell you a lot, I think, philosophically about where the organization's head is, if you will, and where they're going. Our organization, as a specific example, has budgeted roughly 5 to 10% of compensation toward quality. Our goal in the next 4 to 5 years is to have quality be roughly 20% of physician compensation, and we are not unique in that regard. So again, quality ranges from about 5 to 20% of total compensation. I think most organizations are in that 5 to 10% range, but most experts indicate or suggest that 4 to 5 years, quality will be roughly 20% of your compensation, which I think is a good thing. I'm sure you do too. The other thing I wanted to just touch on quickly, I'm going to finish up with this, is work RBUs. 61% of physicians, this is a two-year-old data, 61% of physicians say that somehow, some way, work RVUs are a component of their compensation. And frankly, I'm a little surprised in my recruitment activities, particularly when I talk with residents and fellows, a lot of them are like, well, I don't really know what a work RVU is, and how can I relate to that? So it's important to educate yourself on work RVUs because it is such a key part of compensation packages nationally. I would suggest to you, it's not like you have plenty of free time on your hands if you're a resident or fellow, but I would try as best as you can to spend some time, if you're in the clinic, get to know a really reliable coder, maybe your PSA or MA, whoever does the coding, and just maybe pick their brain about, they may not necessarily know about work RVUs, but they probably have a sense of CPT codes and things like that. And I'll show you here, kind of give you a crosswalk. Perhaps maybe you can put work RVUs in a context. I'm going to go back to that in a minute. So, new patient office visit CPT code 99201. That's actually worth 0.48 work RVUs. If it's an established patient and you're doing a wellness, you can see the work RVUs go up. And the idea is work RVUs are a measure of the time and effort and the resources used to provide or deliver care to a patient. So the more time, the more care, the higher the work RVU value. The other thing I would suggest, if you're not already familiar with national compensation data, you could look at MGMA, the AGMA, Sullivan, Cotter, Hayes. I mean, there's all kinds of survey organizations that look at this data. Our organization, we like to use a composite of the three big ones, MGMA, AMGA, and then Sullivan Cotter. National median work RVUs is 5,000, that's annual. The national median cash comp is 205, and this is for a full spectrum pediatric practice. If you're just talking strictly adolescent medicine, it's 175. And what I would point out to this to you is this is not equivalent to salary. This is total cash compensation. So, and remember, it's a measure of central tendency. It's the median, not the mean. So it's not a mathematical average. Hopefully we're taking out the extreme high producers or low producers. It's an average of location. Other benefits you want to look for, these are pretty typical. Does the organization provide malpractice insurance? Most do. I think the question you want to ask is, does that include tail? And so sometimes there's confusion about, well, if you're leaving a practice and then you're maybe joining another organization, when organizations generally say, well, we provide malpractice with tail, they're not talking about tail from the opportunity you're just now leaving. They're talking about tail at the end of your employment with that organization. So if you worked for the organization and then you left, is that tail coverage provided? So, and is it on a claims incurred basis or a claims paid basis? These are really highly technical issues. You would presumably have legal counsel or a tax accountant to help you with some of this. But again, I think the big thing is, does your malpractice insurance, if you provide it, does it include tail? Because that could leave you exposed from a liability standpoint if they don't. And there's a variety of other options. I think the loan repayment, sign-on bonus, retention. Generally, the sign-on bonuses and retention bonuses have pretty significant tax consequences. They take a huge, if any of you have been practicing for a while, you know this. You get a huge chunk taken out, whereas loan repayment assistance, oftentimes if it's structured as a promissory note, doesn't have the adverse tax consequences that maybe perhaps a sign-on or a retention bonus might have. The other thing when you're looking at this and working with your lawyer, make sure you know the finer points about, let's say, loan repayment assistance. So an organization will say, well, we'll give you $30,000 a year in loan repayment, but okay, so what's the catch? What's my obligation? Does that mean that I have to stay for 2 years, 3 years? Is it a time commitment? Or if I leave early, how much, if any, do I have to repay of that? So if it's a 5-year contract, is it a straight line situation? So if I work for 4 years out of 5, you may be responsible for paying back 20% of that original bonus. So again, it's all about the fine print. And then of course retirement plans, CME and PTO. Again, these are pretty kinds of standard things. I would suggest that when you look at opportunities, look at the total compensation, and I define that very broadly. I'm not just talking about financial compensation, whether it's productivity, quality, even retirement benefits, the dollar value of CME or PTO. I would actually go beyond that and say, do I feel like I'm a fit in this organization? Is the organization's mission consistent with my personal values? These may sound kind of esoteric or high-level kinds of things, but these are the things that generally indicate or suggest which physicians stay with that organization. And this is not like any other job. I mean, physicians, if you start having 5 to 6 stops in your career and you want to move to the next job, a lot of employers are like, well, you kind of move around a lot. You don't really stay in one place for more than 3 years. So you have, you only have a couple shots, I think, to get it right. And then I think the last thing is the community fit and the support. This actually goes back to what I was saying earlier about Realtor.com. So I think a lot of folks are just looking purely at, well, what are you going to pay me? What's my salary? What's the work RVU? What's the quality? And they're kind of limiting their analysis to that. But housing is, for most people, your largest living expense, your largest expense in your monthly budget on a family level. And if you might look at a country where the housing cost is maybe 80% of what it is in, say, Chicago or New York, just something to consider and think about as you're weighing what I consider to be the entire package. So again, I always tell physicians when I'm talking with them, there is no perfect opportunity. If you think there's a perfect opportunity, I would suggest to dig a little further and maybe talk with the practicing pediatricians in the community a little bit more. No opportunity is perfect. To me, it's all about checking the boxes, right? So you know what your criteria is, and maybe there's 5 things that are must-haves. How many opportunities, how many boxes are checked? Because you need to do what's right for you and your family.